Hello, my name is Michael Covell, and I'm a second-year medical student at Georgetown University School of Medicine. I will be discussing our study titled The Limited Utility of the Hospital Frailty Risk Score as a Frailty Assessment Tool in Neurosurgery, a Systematic Review. Thank you to Dr. Christian Bowers, my co-authors in the Bowers Neurosurgical Frailty and Outcomes Data Science Lab, and the Neurosurgery Publications Journal Highlights Group for the opportunity to share our work. Frailty is defined as decreased baseline physiologic reserve and manifests as vulnerability to internal and external stressors. Many indices exist to quantify patient frailty, one of which is the Hospital Frailty Risk Score, or HFRS. The HFRS has seen widespread application to neurosurgical patient populations and widespread proliferation through leading neurosurgery journals. First introduced in The Lancet in 2018, the HFRS was developed through an observational study on hospitalized patients greater than 75 years old, exclusively presenting to acute care facilities. The objective of the present study was to review and critique HFRS's logic and scientific validity for neurosurgical frailty assessment. We performed a systematic review of the literature per PRISMA guidelines. We screened 99 studies, of which 17 used the HFRS in a neurosurgical patient population. 8 of these studies were in cranial patients, while 9 of these studies were in spine patients. We described 10 core frailty principles for frailty-based neurosurgical risk assessment. The HFRS was compared to 2 other common frailty indices in the literature, the Risk Analysis Index, or RAI, and the Modified Frailty Index, or MFI. We highlight that the HFRS disagrees with all 10 of these core frailty principles. HFRS scores are impacted by acute symptoms and resemble a patient's chief complaint. HFRS does not differ from a common comorbidity index. It cannot inform personalized care, and it does not allow for global implementation given its extensive coding design. Additionally, the HFRS is not exclusively applied prior to any surgical intervention. It does not demonstrate accurate outcome prediction, and lastly, it cannot be applied to individual patients in any clinical setting. We also demonstrate how HFRS frailty scores are inflated due to ICD-10 code inclusion specific to neurological disease. This results in patients being labeled frail despite having classic symptoms of their neurological illness. For example, convulsions not elsewhere specified, intracranial injury, and other hearing loss are all awarded frailty points. As a result, otherwise healthy patients may be labeled as suboptimal surgical candidates based on inaccurate frailty strata. The HFRS pioneering group admits many of these limitations in the score's design. They stated, HFRS can only be generated after an initial admission, so risk stratification information would not be possible at first presentation. They also note that HFRS is mainly applicable for service planning, but not sufficient for individual clinical decision-making. They suggest HFRS may be used as a frailty risk marker in epidemiological studies using administrative data worldwide. We believe HFRS is unsuitable for frailty-based neurosurgical risk assessment, and the score should no longer be applied to neurosurgical patients. We recommend the Risk Analysis Index, or RAI, for frailty-based neurosurgical risk assessment. The RAI has shown strong discriminatory accuracy for neurosurgical outcomes and can be prospectively deployed at the point of care by the bedside to guide personalized care. Thank you so much for listening.